So clinically resectable pancreatic ductal adenocarcinoma. Patients with clinically resectable pancreatic ductal adenocarcinoma can be managed with upfront resection or neoadjuvant treatment sequences. And generally, tissue confirmation should be obtained, especially if neoadjuvant therapy is planned, or if diagnostic workup suggests a plausible alternative diagnosis like focal or chronic pancreatitis, lymphoma, autoimmune benign stricture. EUS-FNA is the most effective option for obtaining tissue diagnosis with accuracy is almost more than 90%, and if the diagnosis is reasonably certain based on the imaging and clinical history, tissue confirmation is not necessary if the surgeon first approach is planned. It is important that the patient is made aware of the low but not zero likelihood that the final pathology may be discordant with the working diagnosis, and in the absence of tissue diagnosis and radiographic features suggestive of autoimmune disease, serum IgG test is helpful prior to commencing resection. Endoscopically placed biliary stent is not mandatory in jaundice patients with a right-sided pancreatic ductal adenocarcinoma if surgery is planned first and the patient is otherwise optimized from medical and nutritional standpoint. Vandergaag and Kali, they conducted a multi-institutional prospective trial that randomized 202 patients with localized pancreatic ductal adenocarcinoma and obstructive jaundice, total bilirubin of 2.3 to 14.6, upfront surgery or preoperative biliary drainage, with the surgery after 4 to 6 weeks after stent placement. And the authors found that stent placement resulted in an increased risk of serious complications, overall 74% versus 39%. So approximately half of these complications were related to stent placement itself. And surgery specific complications were also higher in the stented group. So complications were higher in the stented group, including wound infection. Pancreatic or duodenectomy is usually safe in jaundice patients with normal renal function who are not coagulopathic. So normal renal function, not coagulopathic, and jaundice. And the bilirubin threshold associated with the adverse outcome following pancreatic duodenectomy has not been definitively elucidated, and a recent prospective 803 patients from the University of Pennsylvania group suggests that a cutoff of more than 13 that is associated with the higher 90-day post-operative mortality if it is more than 13. And when a stent is indicated, plastic is cost effective and appropriate for patients who need short-term drainage prior to pancreatic or duodenectomy or if the prognosis is poor. For patients who will need longer term endobiliary decompression, self-expanding metal stent, whether covered or uncovered, they are preferred in a randomized trial of 119 patients of localized pancreatic ductal adenocarcinoma treated with neoadjuvant therapy demonstrated no significant difference in overall patency rate between covered and uncovered metal stents. Tumor regrowth, they were more common in patients with uncovered stent. So stent migration were more common with the covered stent. And the rate of cholecystitis when the gallbladder was in situ was higher in patients with covered stent. But this not reached statistically significant. So what neoadjuvant therapy is for clinically resectable pancreatic ductal adenocarcinoma? Historically, a traditional paradigm for management of resectable pancreatic ductal adenocarcinoma has been surgery followed by adjuvant therapy. So historically it is surgery followed by adjuvant therapy. And it is important to mention that nearly all existing retrospective and prospective literature revolves around this anatomical resectability, and no prospective single-arm randomized studies have examined the efficacy of the treatment sequence in patients who are anatomically resectable but have a biological and conditional borderline features. So the median survival following pancreatectomy alone for pancreatic ductal adenocarcinoma is 18 to 24 months or less, which has led to the re-examination questioning of the histological paradigm. Conceptually, there are strong rationale that favor a neoadjuvant treatment sequence in the management of clinically resectable pancreatic ductal adenocarcinoma. At the time of diagnosis, pancreatic ductal adenocarcinoma is likely a systemic disease in most patients. So it is a systemic disease. Mentioned above, approximately 50% of the patients have clinically evident metastasis at the time of diagnosis. In overall, 80% patients will develop metastasis disease at some point of time in their disease course. So cluster study, they demonstrated circulating tumor cells are present in 96% of the patients with localized potentially resectable pancreatic ductal adenocarcinoma, and the number of circulating tumor cells decreased in patients who receive neoadjuvant therapy. So an elegant study of Hino and colleague used computational models to demonstrate, amongst other things, that a patient with a 1 centimeter primary tumor had a 28% probability of harboring distant metastatic disease. 1 centimeter primary tumor had 28% probability of harboring distant metastatic disease, and this increased to 73% with a tumor size of 2 centimeter and 94% with a size of 3 centimeter. And additionally, their model suggests that all primary pancreatic cancer harbor capable of metastasizing regardless of the tumor size. And modern systemic chemotherapy consists of multi-agent regimens, and these are more likely to be administered and better tolerated prior to resection. A significant proportion of patients suffer post-pancreatectomy complications, have prolonged recovery that precludes the receipt or completion of recommended adjuvant chemotherapy. And this can be avoided by changing the sequences of when the most difficult aspect of the multimodal therapy is performed. In theory, neoadjuvant treatment sequence maximizes the number of patients who receive potentially beneficial multimodal therapy. In a retrospective study from MD Anderson, 83% patients with the anatomically resectable tumors completed multimodal therapy like chemo, radiotherapy, chemotherapy, surgery, with neoadjuvant treatment sequencing compared to 58% who were managed with the surgery first. So 1 year cancer specific mortality following upfront resection is approximately 30%. 1 year cancer specific mortality 30%, suggesting a sizable number of patients are not helped with the surgical intervention. Following upfront resection, 77% recurrence within first year. So within the anatomical resectable cohort of the patient, neoadjuvant therapy introduces an opportunity to better select patients who may benefit from the pancreatectomy from a biological and conditional standpoint. So proponents of the neoadjuvant approach believe that patients who progress while on neoadjuvant therapy would likely have progressed in the early post-operative period. So patients who have progressed on the neoadjuvant, they would likely progress in the early post-op period, and those who experience performance status declines precluding operative intervention would have likely tolerated pancreatectomy poorly and not received adjuvant therapy. Thus, in addition to the potential oncological benefit, neoadjuvant therapy can function as a conditional and biological pressure test and improve patient selection for operative intervention. Neoadjuvant treatment sequencing in conditionally borderline patients allows treatment of disease while comorbidities, nutrition, performance status are potentially optimized. So while these conceptual arguments from neoadjuvant approach are compelling, there are several arguments again and potential barriers to preoperative therapy in patients with resectable pancreatic ductal adenocarcinoma. So tissue diagnosis is required to give systemic therapy, and USFNA is highly accurate. And there remains a proportion of patients where biopsies are indeterminate and diagnosis cannot be confirmed. The incidence of post-EUS pancreatitis is low, but 6% of patients suffer EUS complications. Post-ERCP pancreatitis occurs in 10% of the patients who require biliary stent, and in rare instances can result in technically unresectable scenario as a result of locoregional complications of pancreatitis, including thrombosis of the SMV portal vein, pancreatic necrosis, and hemorrhagic pancreatitis. Stent-associated acute cholecystitis that occur in approximately 10% of the patients, but can result in a patient with delay during neoadjuvant therapy, can result in treatment delay during neoadjuvant therapy, and the complications have downstream consequences with regard to ease and feasibility of surgical resectability as well as post-operative complications. Advanced computational models suggest that chemotherapeutics are most effective when the tumor burden is low, such as post-resection, because there are fewer opportunities tumor cells to develop cross-resistance to therapy given the selective pressure applied by anti-cancer drug. By definition, neoadjuvant therapy is performed in the presence of high tumor burdens, like localized but grossly visible primary tumors, and there exist more opportunities for individual tumor cells to acquire resistance to anti-cancer therapeutics and breed resistant clones. In concept, this argument favors adjuvant therapy following resection of grossly visible disease and pancreatectomy function as a cytoreductive surgery. So results from retrospective cohort studies as well as observational studies have demonstrated improved overall survival in patients who were treated with the neoadjuvant therapy compared to those who have reportedly historically for patients managed with the surgery first. Christian and colleague reported 69 patients who received neoadjuvant therapy for resectable pancreatic ductal adenocarcinoma, and a total of 60 patients underwent pancreatectomy, whereas 8 patients developed metastatic disease and 1 patient had decline in performance status. So R0 resection was achieved in 97% of the patients who underwent pancreatectomy, and median OS was 31.5 months with the entire cohort, and 44 for patients who underwent resection. So O'Reilly et al. Conducted a non-randomized phase 2 of neoadjuvant gemcitabine and oxaliplatin. Gemcitabine is 1000 mg per meter square. Oxaliplatin 80 mg per meter square every 2 weeks, followed by gemcitabine 1000 mg per meter square on day 1, 8 and 15 every 4 weeks, and 38 patients with anatomically resectable pancreatic ductal adenocarcinoma. A total of 35 patients completed all the neoadjuvant and 27 underwent pancreatectomy. 26 patients started adjuvant and 23 completed all the planned surgery, and on the intention to treat analysis 18-month survival was 63% and median OS was 27 months and median DFS was 30 months. The median recurrence-free survival was who underwent resection was 22 months. An observational study of Mogdad and colleague that compared the upfront resection to neoadjuvant over 15,000 clinical stage 1-2 patients with proximal pancreatic ductal adenocarcinoma between 2006 to 12 demonstrated neoadjuvant therapy was associated with the improved OS and improved pathological outcome. More recent analysis captured in this modern era multi-agent systemic chemo confirmed these findings in patients with pancreatic ductal adenocarcinoma of the head as well as pancreatic body and tail. And since the last edition, several randomized controlled trials testing benefit of neoadjuvant approach anatomically resectable pancreatic ductal adenocarcinoma have completed accrual and published results. However, controversies remain regarding the optimal regimen, duration of neoadjuvant therapy, and the role of radiation therapy. Additionally, one major pitfall of nearly all published trials is they randomize patients into one size fits for all regimen. A major challenge in the future will be improving the precise choosing of preoperative treatment regimens. And a recent published phase 2 study by Wisconsin group demonstrated feasibility of molecularly profiling of the US FNS specimen of 130 patient, and this 95%, 73% basal specimen cellularity and 71% had profiling that guided treatment towards 5-FU based gemcitabine based chemotherapy. Complete or near complete pathological response was seen in 20% of the patients at median OS of 107. In the 107 patient who completed all preoperative therapy was 45 months.